Okay, so for these webinars, all lines have been muted. You should see a control panel in your right-hand corner. In order to minimize that control panel so it does not block the PowerPoint, you want to click on the orange button. That's going to bring it down to minimize so that it will look like you'll have a smaller panel there. In addition to that, so that you know that there will be a question and answer period. Again, the lines are muted, so you're going to want to use that chat box that's going to be in that right-hand corner in order to submit questions, and we'll summarize questions and answer as much as we can on these calls. The questions that we're unable to get to, we will post them on our website as well. And again, you'll have your dialog box there, and that's where you'll submit your questions. For attending these webinars, you will be awarded 1.5 CEUs from NADAC and NBCC as well. You'll receive an email from the Donnie Institute within 10 business days with your certificate. And now that we've gone over the housekeeping rules, I'm going to now turn it back over to Ryan, who's going to introduce Dr. Stephen Gallen.
Sure. Dr. Gallen has been working with us for many years, actually. He's previously ATTC director before. He's now retired to some degree. And of course, we keep working him hard, but we're glad to have him working with us now. And he's a national trainer on clinical supervision. He's been involved in putting this curriculum together for you. And with that said, I'd like to introduce Dr. Gallen. Go ahead and get started.
Hey, thank you, Ryan, and Tamara, and Deanne at the National Office. I want to thank you all for inviting me to lead this seminar series. And I'm just getting my PowerPoints up and ready to roll here. I trust that everybody can see that. Ryan talked about the development of our clinical supervision products throughout the ATTC network. And one of the products is this series of webinars that we're hosting on the first Friday of every month from now through September. So you can see the upcoming topics. They're all scheduled at the same time, 11 o'clock Pacific, noon Central, and 2 o'clock Eastern. And next time we'll be talking about boundary issues, which are really a topic that springs from the discussion we're going to do today around liability. And you can see the rest of the topics there. Today's topic is vicarious liability. We're also going to address issues of direct liability as well. So we'll be talking about liabilities that supervisors face as they embrace their role in an agency where they have responsibility for oversight of the work of clinicians and others in the organization. As I was getting ready to do this webinar, I did some internet searching, and I was a little bit shocked to what I found. When you do a Google search or an internet search with your search engine, and you type in the words vicarious liability, within half a second, literally a half a second, 1.86 million entries pop up on the Google search. I then said, oh my goodness, how am I going to review current information so that we can make this presentation as current as possible? So I limited the search then to counselor and clinical supervision liability. And the number of entries went down to a little over 150,000. That's certainly more manageable than 1.86 million, but it's still a daunting task. That's really by way of saying that this is a complicated issue. A lot has been written about liability, supervisory liability and agency liability, as we engage in clinical services that are fraught with all kinds of potential risks. So today I hope we're going to reduce some confusion that might exist out there with regard to what are the limits of liability that we face. hopefully add some clarity to some safeguards that we can take to minimize our risk, and talk some about some difficult or complex issues that sometimes we need to manage as we oversee the work of people working with clients who have either mental disorders or substance use disorders, and often a mix of both of those, along with some physical diseases or limitations that make our work very complicated. We're going to start by considering a case, if you will. I'm going to tell you a short story about Marcia, and we'll go from that story into a discussion of potential liabilities that Marcia might be facing, and then hopefully some clarity around some of the issues. A couple of years ago, Marcia was hired as the clinical director in a behavioral health agency that provides services to people with both substance use and mental disorders. Her goal was to provide a quality clinical supervision program. So she established opportunities for her to monitor job performance. She established a schedule of regularly occurring supervisory sessions with her supervisees. She valued and knew the importance of providing performance-based feedback to her supervisees, and the importance of gathering first-hand information, first-hand observations of counselor skills and abilities. And she also instituted a process within the organization so that she could continually assess and provide opportunities for improving clinical services. Well, things went very well for the first 18 months, and the staff really were appreciative of her efforts to establish a good clinical supervision program. However, hard times began to emerge in the community that the agency was located in, and funding became a challenge for administration. And as a result, sharp budget cuts were implemented. And at the same time those budget cuts were implemented, Marcia noticed that there was a surge, an increase in applications for service and in the caseload. So she had kind of this, she was caught between a rock and a hard place, in the sense that she had, the agency was implementing some austerity measures, and she had, and her staff had more clients to serve. As that happened, clinical vacancies, as staff left, there was a freeze on hiring at the county level, so they weren't able to replace staff. And as a result, both Marcia and her clinicians became overworked. They really had more requests for service than they could serve. So Marcia began to make an adjustment in the way she did supervision, and she began to put out fires. And unfortunately, she felt like she had to curtail some of her regular supervision activities. She tried to assure the staff that that suspension of those supervision activities would be temporary, but unfortunately the crisis continued for some time, and she wasn't able to reinstate the activities that she engaged in. So she was really involved at this point in putting out fires. She wasn't able to meet regularly with her staff, and her ability to observe staff doing their work was extremely curtailed. Last week, then, all of this culminated in the agency being notified that they were being sued by a client, naming a counselor on the staff and Marcia, the clinical director, as co-defendants. Apparently, there had been a client who believed that she had been abandoned in services being provided by the agency, and she subsequently lost her parental rights due to her failure to complete a treatment program that was required by Child Protective Services. And at the same time, Child Protective Services had not been contacted by the agency. That resulted in the client seeking legal assistance and filing a suit against the agency, against the counselor, and against Marcia. So that presents a number of issues for us to think about. And these are the issues that I think we'll address today as we proceed for the next hour or an hour and a half to take a look at these issues of liability. Could Marcia be legally at fault for failing to provide adequate supervision? Could she be legally at fault for and responsible for the actions or inactions of one of her supervisees? She wasn't directly involved with this case, but did she have some liability? If she had some liability, that makes us think about, well, what are some of the common liability issues that supervisors face as they engage in their role of overseeing the work of clinical staff? And are there some then basic risk management principles that Marcia could follow that would minimize her exposure, would minimize her liability, and minimize the liability of her agency and her staff in response to client complaints? If there is a client complaint, another question that this little case study reminds us of is, how do we go about investigating reports of wrongdoing? What kind of questions should we ask? Who should we ask those questions to? And then how do we judge the credibility of the answers to those questions? Another issue for us to look at. And then finally, what are some practical safeguards that can protect us from liability complaints? So these are the 6 issues that we're going to address today, and hopefully at the conclusion of our presentation and your experience with this webinar, you'll be able to answer these questions and you'll have some ideas. I would encourage you to kind of listen as we move through this material. The material can be complicated. There's a lot of information to share. And I know that Ryan and Tamara will be posting these slides on their website at the Danya Institute and the Central East ATTC. So you'll have access to these slides as we in the weeks to come. So I encourage you, if it helps to take notes, terrific. If you'd rather just sit back and listen and try to absorb, that's great too. We'll also have an opportunity for some question and answers as we proceed. So I'll be letting you know when a question and answer period is coming up so that you can use the chat box to enter your questions, and then Tamara will field those questions and she'll be the one relaying the questions to me. All right, so let's get started. Let's first of all do some definitions. And we build this as a focus on vicarious liability, so let's take a look at that issue first. What is vicarious liability? It's basically when a supervisor or an agency is held responsible for an action of another person. That's what vicarious has to do, means. The vicarious liability has to do with the supervisor being responsible for something that someone else on the staff does, even though they weren't personally involved. Vicarious liability often exists in an agency setting where one person has responsibility for and control over the actions of another. And the assumption legally is that supervisors do have responsibility for making direct work assignments and monitoring the quality of that work on the part of their supervisees. All of this is based on a legal doctrine that you'd see if you did some research into the literature called respondent superior, also sometimes refuted as imputed negligence. And as we look at some more specific examples of supervisor liability, what we're going to come down to in most cases has to do with the definition of negligence, has to do with whether or not the supervisor is doing the job expected of a supervisor. So we're going to take a look at what some of those issues are. The doctrine of respondeat superior comes from this notion that an employee is held to be an agent of the employer. And as such, when the employee is acting within their role of an employee, the employer can be held for any damages that the employee is responsible for. Now let's look a little bit more closely at the supervisor and the supervisor's responsibility. What are the conditions of liability that a supervisor faces? This is a crucial definition here, and it's important for us to understand that if an employer knows that a person is not doing their job appropriately, or has reason to know, meaning that we've heard about it from somebody else, or we should know but didn't investigate, or didn't observe, or didn't have first-hand experience with the counselor's skills and knowledge and abilities, then the supervisor may be held responsible for an employee who does something incorrect or doesn't carry out their duties in an appropriate manner. Another way to think about that is that if we fail as supervisors to properly supervise employees in performing their assigned duties, we can be held liable for their actions. Now, I said we'd be looking at both direct and vicarious liability, so let's try to distinguish between what the difference is between direct and vicarious liability. Let's look at direct, and then we'll look at vicarious. Direct liability has to do with the supervisor doing something inappropriate or not acting in a way that's consistent with professional practice guidelines. Now, there are a lot of professional practice guidelines that are emerging for supervisors. The Association for Counselor Education and Supervision has a set of ethical standards that they suggest supervisors subscribe to. The National Association of Social Workers has a set of standards. AAMFT, the American Association of Marriage and Family Therapists, has a set of standards. And the American Psychological Association has a set of standards. The International Certification and Reciprocity Consortium, ICNRC, also has standards, and NADAC has standards. So there are multiple sets of standards. What's important here is to realize that the court, in a situation where there's a contest or a tort claim by a client or an agent of a client making a complaint about services received or not received in a clinical setting, the court can review those sets of standards and make assumptions and definitions of what they believe constitutes professional practice. And if the supervisor is found to be acting outside of those professional practice guidelines, the court can find us liable. So it's important, really important for us to be aware of what those practice guidelines are. I'm also, as a supervisor, directly responsible for the advice that I give to supervisees. If I make a suggestion that a supervisee take a particular action and that action turns out to be inappropriate or harmful from the perspective of the client, then the client may have a grievance, may have a complaint, may result in legal action. So I've got to be careful about the kind of advice I provide. And then also, do I make assignments that are consistent with the training and education and scope of practice of the supervisee? Another critically important area. One of the places where I see violations of that principle relatively often is in the case of students who are in a practicum or an internship with a behavioral health agency. And in a typical scenario, for example, they've been sitting in on group therapy with their mentoring counselor, and the mentoring counselor becomes ill or goes on vacation, and the supervisor asks the student to take responsibility for the group, for one night or a series of meetings. If that supervisee has not been adequately trained, doesn't have adequate skills to facilitate a therapy group, for example, or an educational program, I could be liable as a supervisor for making that assignment if something untoward happens during the course of the group meeting. Just one example of how we need to be careful about the assignments we make. Another case in point, I think it happens less now than it used to, is who do we assign to do assessments in our agency? Is it the assessments and treatment planning? Is it the most skillful clinician we have? Because our clients are more complicated these days, often suffering from co-occurring disorders. Do we give that responsibility to someone who's thoroughly trained and clinically proficient, or do we give it to a person who has less tenure, less training and experience, maybe the newest member of the staff? Sometimes even a student gets assigned to doing those kinds of assessments. In my view, that might be an inappropriate assignment of task. And if the wrong decision gets made, if a diagnosis gets missed, an inappropriate recommendation is made, it could be that the agency would be held liable for that kind of an action. So you can see that there are things that we should be thinking about in terms of making assignments, making sure that those assignments are commensurate with the skill level, the education and training of the people we make the assignment to. Now, vicarious liability has more to do with how we go about practicing supervision. And there are criteria for determining the degree to which I might be vicariously liable for the actions of a supervisee. And here are their criteria on this page. There are 3 criteria that the court typically uses in determining whether the degree of liability that might be incurred by a supervisor. Do these conditions exist? Has the supervisee agreed to supervision? Is there either a written and explicit contract, or at least an informal and verbal contract, an agreement to enter into supervision? If the supervisee has been supervised by a period of time by the supervisor, then the court assumes that there is an agreement. Does the supervisee act within the assigned scope of activities? The supervisee needs to be acting within assigned scope of activities in order for the supervisor to be held liable. If the supervisee acts outside of that scope of activities, engages in an activity that was not authorized by the supervisor, was out of the knowledge of the supervisor, might not even have been on site or on location, that minimizes, doesn't eliminate totally, depends on the judge and the court, but it minimizes the likelihood that a supervisor would be held liable. And then the third condition or criteria is that the supervisor actually within the agency has the power to direct the supervisee's actions, make work assignments, schedule them, review their work, give them feedback, and perhaps be responsible for periodic performance reviews. Assuming that those 3 criteria are in place, then and the action occurs consistent with those criteria, then there might be some liability on the part of the supervisor. Let me share with you some examples, give you some legal examples, some cases that have established or gave rise to some of the rules that we have now that we're operating within. I'm going to talk about 3 kind of classic cases in the legal literature that affect the way we design practice guidelines for supervisors and the way we think about the role of the supervisor in clinical settings. The first one is a 1984 case from South Carolina, Andrews versus the United States of America. In this situation, this is not a behavioral health situation, but I think there is a strong parallel here in terms of drawing a clearer definition of what is supervisor liability. In this particular situation, a physician's assistant was working for, a physician was the supervisor, the physician's assistant was the person working with the patient, and in this situation, the physician's assistant developed a sexual relationship with a patient. Subsequently, the patient sued the practice, and the supervising physician was found negligent for this reason. The supervising physician had heard from a third party, from another patient, that this relationship existed, this sexual romantic relationship existed between the physician's assistant and another patient. And the supervisor failed to investigate. The court said that if the supervisor had actually investigated, inquired with the supervisee, brought in the patient, talked with the patient, literally did an investigation of what happened, then the supervisor might not have been held liable in this particular situation. So it was the failure to investigate, which is instructive for us, that the court found objectionable. In another case, this is a classic case that many of you have heard about. It's the case of Tarasoff versus the Regents of the University of California. This particular case set the standard and gave rise to a whole lot of guidance from both the federal government as well as professional associations with regard to our duty to warn people who might be at risk of harm when we hear about the potential harm from a client. So this is really talking about circumstances in which we violate the confidentiality statute and go and report to a third party that they might be at risk or in danger. Here's what happened. Dr. Thomas Moore was a counselor at the University Counseling Center in Berkeley. And he had a client who told him about his intent or his wish or his plan to murder his ex-girlfriend, Taliana Tarasoff. Dr. Moore took this threat seriously. He reported it to his supervisor, and he notified the police. And the police interviewed the patient and released the patient. And I'm not certain what the police concluded as to the degree of threat, but they released the patient. 2 months later, after the patient had terminated the relationship with Dr. Moore in the counseling center, the patient actually murdered his girlfriend. So the family brought suit against the university, and the court decided that the supervisor was responsible, as well as the counselor, for notifying a patient. Now, the supervisor was held responsible because, number one, the supervisor never saw the patient, even though the supervisor got a report from Dr. Moore, chose not to interview the patient, and did not review the medical record that Dr. Moore created in documenting the threat. So the supervisor didn't read the record, didn't talk to the patient, got the verbal report from Dr. Moore, heard that the police had contacted the patient, and assumed that the liability or the responsibility for taking any further action was mitigated by the fact that the police released the patient. Well, the court came back and said no. The supervisor and the counselor were responsible for violating the confidentiality regulation, going beyond it to warn the patient, the intended victim, of impending peril. In fact, the court, in its written statement, provided this quote, which has guided the development of practice guidelines in the last 30 years. And that quote is, "The protective privilege ends when the public peril begins." So if we have knowledge of, or one of our clinicians has knowledge of a risk, a potential harm that's taken seriously, that seems credible, we have a responsibility to inform the intended victim. And the counselor, in this case, who did report to their supervisor, the supervisor has a responsibility to follow up and investigate. So making sure that our counselors know that they need to let their supervisor know if they hear of any threat, and let the supervisor determine the degree of seriousness of the threat is very important. And then, if the report seems credible, then acting further to notify the intended victim. All right, a third case extends that duty to warn to other situations. This is a situation in which, this is a 1985 case in which a client named Peck came into the counseling service in Addison County and reported that he had had an argument with his father and was intending to burn the father's barn to the ground. Now, in this situation, the counselor didn't consider the threat serious. Unfortunately, the following day, the son did, in fact, burn the father's barn down. When the father brought suit against the county for when the father discovered that the son had discussed this plan with his counselor, the court found that the counselor was negligent due to a failure to look at the patient's prior medical record to determine whether or not he had done similar deeds or made similar threats in the past. There wasn't an adequate history located in the medical record, so the court found the counselor at fault for that. And the counselor didn't raise the issue with his supervisor, and the court was critical of that. Now, the counseling service was also found negligent for this reason, and this is another instructive piece for us. There were no policies or procedures in the administrative codes of the agency that required that a counselor consult with a supervisor when a serious, a dangerous threat was made by a client. So because no policy existed, the counseling service was also found partially liable for the loss. The court said if the agency had had a policy that would require the counselor to report such threats to their supervisor, the agency might not have been held liable. But because they had no policy, they were held liable. Okay, those are three examples of situations that have given rise to these notions of direct and vicarious liability. Now, there's some other things that we should attend to that we can use as supervisors to help us make decisions about what we need to do and the degree to, and judge the degree to which we might be liable in a certain situation. The first area has to do with supervisee behavior. Remember, the criteria for determining liability, vicarious liability, has to do with whether the supervisee is acting within the scope of their assigned duties. So it's important for us to be aware of when an action takes place, where it takes place, and what the staff member was trying to do. What was their intent or motivation in doing whatever the action was. If it's within the boundaries of their work, then there is a liability issue for the agency and for the supervisor. If they're acting outside of assigned responsibilities or outside of their scope of practice, then there's less liability. There's huge liability for the counselor, but less liability for the agency. The third issue that you need to be concerned about is could you or could I as a supervisor have been reasonably expected to assume that the counselor would engage in whatever behavior the counselor engaged in? If I could, based on their job assignments and their history with the agency and my observations of their job performance in the past, if I could have reasonably expected that the supervisor would do, or the supervisee would do whatever it was that was being complained about, that could hold me liable. If I couldn't expect it, if it was totally out of character, if it was outside the boundaries of the agency, if it was something that was explicitly prohibited in the policy and procedures of the agency, then I'm less likely to be held liable. So that's a very important consideration. So where and when events happen and why they happen and what the intent of the supervisee is. Now another issue for us to look at, is what about supervisor behavior? What have I as a supervisor been doing that I might be held liable for? One issue is, do I have any conflict of interest? Is my interest solely the welfare of the client and the supervisee, or do I have a conflict? For example, if I don't assess when a client might be appropriately stepped down from one level of care to the next, if I keep a client, or I encourage a supervisee to keep a client in care longer than they need to because perhaps in the back of my mind I know that the insurance company pays a substantial fee for the services we provide, or if I'm needing to keep the caseload high to meet state standards, then I might keep a client or encourage a supervisee to keep a client in treatment in a level of care that's a higher level of care longer than they need to. That is a conflict of interest. The court would find an exception to that. So am I watching and helping supervisees make decisions about when to step patients down from one level of care to the next? Is my supervision proper is another issue. Do I conform with the prevailing standard, or the agency's standard, or the state standard for providing supervision? Or have I been negligent? Have I not met with the patient, or excuse me, the supervisee very often? Have I failed to observe them? Maybe perhaps I've never observed them doing an assessment or leading a therapy group or watching a tape of them individually interviewing a client. I don't really know what's going on behind the closed door of the counselor's office. I can be held liable for that. And then lastly, is there a causal relationship between whatever the injury is and my job as a supervisor? If a client has been harmed in some way, is it reasonable to expect that I could have done something to prevent that, or I should have done something to prevent that if I was exercising my responsibilities as a supervisor in a way that was prescribed for me by either professional practice guidelines or the agency policy? If I had been doing my job more effectively, could I have prevented the injury from happening? If so, I could be held liable. So supervisor behaviors that we need to keep aware of. So when does our liability increase? Here are some examples of events. If they don't happen, if we fail to do these things, then our liability increases. So in a way, this is a bit of a checklist for you in thinking about the way that supervision gets implemented in your agency. First of all, do I provide adequate information and training to my supervisees? Do I let them know what supervision is, what the supervision program is in the agency and the purposes behind the supervision program? And do I clearly lay out the job description and the scope of practice for the supervisees? And are the agency expectations clearly stated in writing? And then are those reviewed periodically? If not, that increases my liability. Secondly, do I review the work of the counselor, the job performance of the clinical staff, assess their skill level and provide them additional training or make it available in some way or plan it in some way so that the staff skills remain appropriate to the services they're providing. If I'm not reviewing their work regularly and not assessing that skill level, I increase my liability. What if a treatment plan is inadequate? Or what if a client gets assigned to the wrong level of care? Could I be held liable for that? Yes, if I'm not monitoring services and determining the degree to which they're appropriate and being delivered in a professional fashion, my liability increases. I need to be able to assure agency management and the public that services being provided under my supervision are being delivered in the best manner possible. I need to make some effort. Now, we can't control everything that goes on behind closed doors, and I certainly can't be responsible for everything a supervisee does. But if I've done some of these things that we've just been talking about, my liability decreases. If I don't do them, my liability increases. What about decisions that supervisees make? Changes in the treatment plan, referral to other agencies, are those appropriate decisions? Am I reviewing those regularly with supervisees? If I'm not, if supervisees are exercising more autonomy than the agency expects or the community expects, then I could be liable. What about times when the supervisee is away? Sick leave, vacation, away for training, some kind of administrative activities, takes them away from their normal clinical services. My job as a supervisor is to make sure there's adequate coverage. If there's not adequate coverage, that could be grounds for a complaint from either a client or someone who's injured by a client or some untoward activity that a client engages in. So making sure that there's adequate coverage, key piece. If I do detect impairment or a lack of skill or inappropriate decisions, what do I do? Do I follow through? Do I act on it to prevent it from happening again and correcting it if something incorrect has been done? And then do I keep a record of it? Do I document it so that if someone on a fact-finding mission were trying to determine whether or not I took appropriate action, there would be some documentation. Meeting regularly with supervisees. If I can't demonstrate that I meet regularly with supervisees, I can be increasing my liability for the actions of those supervisees. So having a program where we meet regularly is important. Group, individual, that's not so important. Just if I'm meeting regularly and am I periodically observing the work so that I know the quality of work that the people are doing. What about situations in which a counselor asks the client to do something and the counselor doesn't want to do it? Many of us have faced that situation. Do we realize that if a client objects to our requirement for them to attend a 12-step meeting or to engage in some other activity that they object to, do we realize that we're increasing our liability in that situation? The court might not find it acceptable for us to ask things for us to ask clients to do things that are against their will. Something to think about. And then finally, and we'll talk more about this a little bit later, do I identify when a supervisee is overly involved? Well, what does that mean, overly involved? How often a client gets scheduled for clinical appointments? How long those appointments last? The degree to which a supervisor feels responsible for the actions of the the degree to which a counselor feels responsible for the actions of the client. The degree to which the client is engaging in recovery activities. When the counselor or the supervisee becomes overly involved, liability for wrongdoing increases. And if I'm not aware that the supervisee is overly involved, maybe engaged in an inappropriate dual relationship with a client, that creates a liability for me. So here, this circle is really kind of a checklist, if you will, for things that we should be doing as supervisors. And if we don't do these things, then we increase our liability. Okay, well, with that in mind, does it give rise to some risk management principles, some basic guidelines that we can use to minimize risk? Sure. First of all, are policies and expectations regarding supervision and supervisee job performance, are they clearly laid out? And are they in writing? Expectations as well as policies and procedures. If so, and as long as supervisees are acting within those guidelines, then there's very little chance of liability. However, if we clearly lay out the policies and expectations and a supervisee chooses to act beyond them, outside the limits of those policies and procedures and expectations, they are going to be liable, but the agency and the supervisor will be less liable. So there's really to our advantage. It's to everybody's advantage to lay out clearly what the expectations are for supervisees. Staying aware of high-risk situations. That means being aware of the kinds of clients that are being reviewed by our and engaging in services in our agency. Being aware of counselor skills. Being aware of counselor weaknesses as well as strengths. All of those things can precipitate high-risk situations. How counselors handle crisis situations. Many outpatient programs have responsibility to be on call to the jail or the emergency room to intervene with situations that law enforcement or medical practice feel like they're unable to deal with. Are we aware of those high-risk situations? Are our counselors prepared to deal with those high-risk situations? And do we review the results of critical incidents when they happen? All of those, very important to be able to demonstrate that we stay abreast of high-risk situations. Does the supervisor provide opportunities for the staff to continue learning, improving their skill? And is there does the supervisor exercise an opportunity to monitor the job performance of supervisees? If we do, and if we're regularly monitoring and giving feedback and developing individual learning plans with our supervisees, we're much less likely to be found liable for the untoward actions of a supervisee. However, if we're not as involved and we are just making some assumptions about the quality of care being delivered behind those closed doors, we're running risk. So knowing the supervisee's strengths and weaknesses, really, really important. Another key risk management principle. Can we demonstrate that we provide job performance feedback? And does that feedback result in coaching or training? Does the feedback result in acknowledgement of good performance so that we can expect that that good performance will continue in the future? So feedback with regard to the quality of care being delivered, whether it's positive or constructive, very important. Giving people feedback, knowing what they're doing and letting them know that we know what they're doing and giving them feedback about how it matches our expectations, really important. Being clear of our own responsibilities, being aware of what the supervisor's job is, what we're legally held responsible for, what those practice guidelines that I mentioned earlier are, very important for us to be aware of those. Investigating complaints. We're going to talk in a little bit about how to go about investigating a complaint, but when we have a concern, either the complaint is something that we register ourselves as supervisors because we see something happening that we're concerned about, or if we get a report from somebody else about something happening, do we investigate it? And then finally, number 8 probably should be, do we document the results? Do we document the results of all of these risk management principles? Do we keep records? We'll talk a little bit later about the records that we might want to keep as supervisors. But the guidelines are clear that we really should be maintaining a somewhat formal record of when we meet with supervisees, what we talk about, objectives that the supervisees have in terms of improving their performance or building new skills, and certainly documenting the results of any investigation we do if we get concerned or we receive a complaint. Very important. Set of risk management principles. Okay, at this point, I'm going to ask Tamara to share with me any questions that might have been typed into those chat boxes that you have in front of you. While we're doing that, while we're getting ready to do that, let me just let you know that on the screen is a web address for a very excellent summary article that summarizes a lot of what I've talked about so far. This article, it's in the JAAPL is the, if I can remember correctly, the Journal for the American Academy of Psychiatry and the Law. And that particular article is relatively recent, 2007. You'll notice that a lot of the cases we talked about were 1974 to 1986. So what's happened in the last 15 or 20 years is significant, and Recupero and Rainey have done a good job of summarizing what the issues are that we're facing. So Tamara, let me ask you, any questions that have come up from the audience at this point that you'd like to share with me?
Yeah, we do. Do you think we have time for 2 questions? The first...
Quickly, yes.
Okay. The first one is a question about is the supervisor still responsible in the situation? They've informed their supervisee of ethical standards and regulations, but they were caught, let's say, sneaking case notes or medical records out of the building to finish them at night, and it was reported or discovered by the single state agency that oversight and license all the providers. Is the supervisor still still responsible?
This is a great question because it gives us a chance to kind of operationalize one of the principles I was sharing. If the agency has very clear written policies and procedures around the maintenance of medical records and the transportability or the lack thereof of those records, in other words, can they be taken out of the building? If there's clear rules about that, and if the supervisor has reviewed those rules, this is another key piece. Just because policy and procedures exist, if they don't ever get discussed between a supervisor and the supervisee, then there might be a case for liability. But if we have periodically either reminded people about the rules, the policies and procedures manual, periodically reviewed particularly sticky or libelous situations like taking medical records outside the building. If we've done that, then the liability incurred by the supervisor is much, much less, especially if the person taking the records outside the building is clearly acting outside their scope of responsibilities and clearly in prohibition of an agency guideline. But that needs to be documented, that the policies and procedures exist and that they've been reviewed periodically with the staff. That will minimize liability. Ultimately, the decision maker in a lot of these cases is either the state or the court. So all we can do is the best we can do and document what we do, and then the responsibility for making a determination about that rests with other folks. But we really lessen our liability if we're clear about what the parameters or boundaries are for the clinical staff. One more, and then we'll need to move on.
Okay. The question: how do you work with a counselor who is in recovery and does not see the ethical implications of being involved with a current or a former client in the recovery network? How do you make sure that the supervisor is not liable for the actions if the ethics of those actions have been addressed?
That's also an excellent question. We're going to deal with those issues, those boundary and dual relationship issues, in the next webinar. So I'm just going to answer that briefly. And that is to say that dual relationships are, especially in when we're talking about recovery from addictive disease and having staff who are also in recovery, the ability to draw black and white boundaries around dual relationships is extremely difficult and really requires a close look at the context. We know we can't prevent dual relationships. In fact, in some cases, dual relationships actually enhance the likelihood of recovery. So each of those cases has to be handled on a case-by-case basis. And what's important is for the supervisor to let the clinical staff, the supervisees, know that when there is an existence of that kind of a relationship where counselors are encountering their clients outside the agency, that they need to let the supervisor know. That's the most important thing. Let the supervisor know. Discuss it with the supervisor, and the two together make collaborative decisions about the advisability or the lack of advisability. And then the supervisor needs to document the decision, because if the supervisee then acts outside the decision that was made or outside the recommendation that the counselor made, then the supervisee may be held accountable, but the supervisor may not. So collaboration, case-by-case, decision-making, and documentation is what I would say is going to minimize risk. Well, thank you for those questions. We actually have, and Tamara, I'm just going to suggest that we take about 30 seconds for this quiz. But Tamara, you're going to, or Deanne in Kansas City are going to show you 3 quiz questions. They're easy to respond to, and my suggestion is let's leave each question up for 15 seconds or so, Tamara, and we'll get a poll and see how people are doing with answering the questions that cover the content we've covered so far.
Okay, so we have the first question up. Okay, we're going to close the polls and it's back. 99% said true. Supervisors can be held liable for both the actions of employees and their supervisory practice.
Great, exactly right. Just the point we were trying to make. How about question 2?
All right, we now have question 2 up. Okay, and 99% said yes again. Can a supervisor be held liable for assigning employees or interns tasks for which they are not adequately trained or prepared?
Yeah, again, exactly right. And my only comment would be, for those of you who are supervisors out there, I encourage you to exercise some decision making and some and care in when you make assignments to people who may not be prepared to do what you're asking them to do. All right, 3rd question.
Okay. All right, we're going to now close the poll. And 79% said true and 21% said false. In general, managing risk comes down to knowing what is going on behind the counselor's door.
Yeah, I expected a little more variability in the responses to this question. My answer to that question is false, largely because it's not only what goes on behind the closed door, but it also has to do with making sure that we fully inform the supervisees of the policies and procedures, rules and expectations of the agency, and we fully inform the supervisees of the supervisory program, the intent of the supervisory program, and how we're going to go about exercising the supervisory responsibilities that we as supervisors have. So in addition to collecting firsthand information and providing feedback and coaching as a result of knowing what a counselor's skills and abilities are, the other piece is so important, having documented expectations and a clear supervisory program that then we implement on a regular basis. Terrific. Thank you for that. Thanks, Tamara. We're going to move forward. We have about a half hour left, and I wanted to review some challenging situations with you, especially two. One has to do with sexual misconduct on the part of clients and or counselors, and how we respond as supervisors to those situations. And the other one has to do with harassment. Literally, the legal complaint is hostile environment. So, because that's a complaint that will sometimes be made against a supervisor who's doing his job or her job in as conscientious a way as they can. So let's first look at this issue of sexual misconduct. This is such a frequently occurring event. Over the course of your career, I assure you that you will know somebody, perhaps have somebody in your agency who is involved in an allegation of sexual misconduct. And it can be a bidirectional issue. So let's talk about this. I thought I'd just share briefly this one instructive case, Simmons versus the United States of America, where a supervisor was held liable for the actions of a supervisee. In this situation, a male social worker was treating a patient with a dual disorder, and over the course of the relationship that evolved between the counselor, the social worker, and the patient, a romantic entanglement emerged. And at one point, when the counselor was out of town on a business trip, the client joined him, and they engaged in sexual activity. After that, the client's psychiatric symptoms deteriorated. She became more acute in her situation, and her family discovered that she had had the sexual liaison with her therapist, and as a result, the family sued for damages. The court found the supervisor negligent because the supervisor, there was no documentation that the supervisor had given any instructions to the therapist about what the limits were in terms of developing a relationship with clients outside the counseling situation, and even what the limits are in terms of kissing or touching within the building, within the clinic. Because that instruction hadn't been documented, and this is a situation where I as a supervisor often just make the assumption that my supervisees understand what the limits are with regard to sexual behavior and developing relationships with clients to whom they're attracted. But if it's not documented, it didn't happen. So the counselor or the court found the counselor or the supervisor liable, and also liable for failure to monitor the emotional reactions that the supervisee was having with the client, was the fact that this romantic entanglement was emerging. So that's instructive to us as supervisors. Now the other piece of it is that there's a significant amount of research been in the last 10 years or so that has been done on what kind of training do supervisors get and what kind of training do counselors get with regard to these ethical boundary issues. And what has been discovered is that good training prior to the beginning of service is an infrequent event for new clinicians. Rarely does this whole issue of sexuality and sexual contact and ethical dilemmas get discussed in any depth. And that supervisors get almost no training in dealing with these issues. So the fact that it happens often and the fact that we don't give it much forethought and we don't have the opportunity to engage in much training really creates a liability for us.
Steve, we lost you for a second there.
All right.
Your audio. If you could repeat that last statement.
Do you have me now?
Yes, if you could just repeat the last statement.
Okay. The last thing was the fact that even though sexual misconduct frequently happens over the course of a career, not each individual, but we all are exposed to others or situations in our clinics that where allegations, at least, of sexual misconduct occur. The fact that we're not trained well ahead of time, that supervisors aren't trained well in how to recognize and how to talk about the issue, and clinicians don't get a lot of training on the ethical implications of developing those relationships. That's important. More recent research has been focused on sexual attraction. How normal is it that there's sexual attraction between a clinician and a client? In this, it's extremely common. On the part of clinicians, Pope and others in this research found that up to 80% of clinicians are willing to acknowledge that at some point in their career they've been sexually attracted to a client. And 40 to over 65% of clinicians say that they have been, that the clients have disclosed to them that the clients have romantic feelings toward their therapist. So it's a two-way street that these things happen. So that really tells me as a supervisor I need to pay attention to the potential for these kinds of things to happen, and we need to talk about it. Now, talking about it is another issue. Zakrzewski did a research project where he asked clinicians, if you knew of a situation in your clinic where another clinician was engaged in sexual contact with a client, would you report it to the supervisor? 53% said no, they wouldn't. That's alarming. Why? Because they feared that their anonymity would not be respected. They didn't want the clinician to be aware of who blew the whistle, basically, and they were concerned about repercussions afterwards. So here we have a situation where people don't like to talk about it, they're hesitant to disclose it, and yet it's normal. At least the not the actions are not normal, but the feelings are normal. So what do? Well, there's a lot of information in the supervisory literature about raising these issues with supervisees. What about our clients? Let's give that some attention for just a second. If a client expresses romantic feelings for the therapist, how can we as a therapist respond appropriately? These are the kinds of things that I think we need to practice in supervision. How do you conceptualize it as a knowledge lack or a lack of skill or a confusion on the part of the client without shaming them? How can we collaborate with the client to help them build skills for talking about these things more appropriately or dealing with their feelings more appropriately? It requires us being willing to engage in what I would call some intimate conversation with clients without acting on it. But for sure, setting very clear limits about what is appropriate behavior for clients. Very important. Clients who are more compromised, who are more seriously ill, are more likely to engage in acting out some of their sexual feelings. With therapists, how do we go about setting limits? It needs to be talked about at the clinical setting. Okay, second issue to talk about is this business of harassment. There's two kinds of harassment that are potential tort claims about harassment that I'm going to talk about. Some that result in tangible employment actions and some that don't result in tangible employment actions. And I'm going to have to go through this fairly quickly because we're running out of time. First of all, let's take a look at, again, refresh our memory about what constitutes the definition of a supervisor. The authority to undertake tangible employment actions, and we'll talk about examples of tangible actions in a minute. the authority to direct daily work activities, and does the employee believe that the individual who's acting in the role of supervisor has that authority? So in the court's mind, it doesn't matter whether it's written down or not. If the employee believes that I'm the supervisor, then I meet the definition from the court's perspective. Tangible actions, what are they? I'm not going to go through this list of 7, but you can see by perusing this list that these are serious actions, usually undertaken as part of a formal disciplinary process. So in order for me to avoid liability in this situation, I need to make sure I document this, and we'll talk about documentation in just a minute. So these are examples of tangible actions. What are the implications? Well, the implications of those actions are that I could be causing the employee, if I'm the supervisor, significant economic harm if I demote them, if I fail to promote them, if I don't approve a pay increase, or I suspend them for a period of time without pay, significant economic harm. Or another example of tangible action, if I alter the employee's status in the agency. They can bring a grievance or a complaint if we demote them, change their job description, change their work assignment, move them from one location to another. So when I engage in those activities, I limit my liability if I follow the agency rules. Usually the agency rules include some kind of official action with documentation in company records. Usually it's reviewed by a higher level supervisor and often requires some kind of formal action, a decision made by more than one person. And as long as we're following agency rules, we minimize our liability, even if the employee grieves our action. Now, another example is where there's no tangible employment action, and this is more likely to result in a tort claim. And the charge is often that the supervisor has created a hostile environment and maybe has threatened the patient, the supervisee, or has done something else that's inappropriate and created a hostile situation. The liability standard here is, do we take reasonable care to prevent inappropriate use of supervisory power? And do we take reasonable care to correct any wrongs that were done? So we need to have a policy and a procedure that, and some practices that actually prevent untoward supervisory action. And then if it happens, we need to act to correct it. At the same time, our liability is lessened if the employee is aware of what the rules are and they don't take advantage of any preventive opportunities, or they don't engage in the correction that we propose. So if the employee resists, that lessens our liability. So what is reasonable care? Remember that one of the issues here is the employer took reasonable care. What's reasonable care? We've got a policy and a grievance mechanism clearly in place that defines harassment or inappropriate use of supervisory power and what supervisees can do if they feel like they're subject to something that's outside of that policy. We review it periodically. We post it in the staff room. We review it periodically with employees. That assures that everybody understands. At least we've made an attempt. And here's a little checklist of the things that we might want to include in our procedures to clarify the limits of supervisory action. So a clear explanation of what's not allowed for the supervisor as well as for the employees. We put something explicit in the policy that protects the person who reports or who complains from retaliation by the supervisor. That the complaint process is really clear. That there's an investigatory process. We protect the confidentiality of the reporter. And then we provide in writing that we're going to do our best to correct if something happened untoward outside the policy we'll do our best to correct. Now, I don't have enough time today to go over these ways of investigating a complaint, so I'm just going to show you the questions that we might want to ask a complainant. It's more than the who, what, when, where, and how, but it's more the qualitative information. What response did you have? How did it affect you or your job performance? Has the person harassed others? Is there any evidence? How would you like to see the situation resolved? Those kinds of questions. Very important for us to have an investigatory template, if you will, for gathering information. And that's the person who makes the complaint. What about the person who is alleged to have acted outside of policy? These are some questions we can ask. So we get both sides of the story before we decide to take any action. And then what about third parties? Are there others who have seen or heard this situation? Can others describe how it occurred and when it occurred? What have others heard? And then finally, once we've gathered all of the information, what do we do with it? How do we sift it so that we can determine whether or not it's a credible complaint? Here are some factors to consider. Important to record your assessment of credibility. Okay, now there are two kinds of corrective actions we might want to take. To stop a harassment, here's a little checklist, again, of things we can do with a supervisor who has perhaps acted outside the boundaries of their supervisory responsibility. Some of them precede a formal disciplinary process. Giving a warning, doing training, observing behavior, all that can be prior to something that could be considered a tangible employment action like a transfer or a demotion or a suspension or even discharge. So there's a combination of things that we can do. Some that precedes the formal disciplinary process, some that should be part of the disciplinary procedures. What about the results of the harassment? What do we go do to how do we respond to the person who is victimized? Again, here's a checklist of things you might consider in order to correct. The court will be very concerned not only did you try to prevent it, but if it happened, how did you try to rectify it? So depending on the actions that were taken, what did we do to make it right for the person who was wronged? Okay, we're just about finished. Tamara, there's a final set of quiz questions. Again, I think they're relatively, they can be answered quickly. So let's engage in the quiz, and then we'll do some final wrap-up.
Okay, so we have quiz 1 up, or question 1 of quiz 2, I should say. We'll give it a couple more seconds, and then we'll be closing the polls. Okay, Steve, 97% said true. Supervisors can be found partially responsible when supervisees violate agency policy or the prevailing code of ethics.
Yeah, that's right. Especially if we have an awareness that there's a potential for it to happen and we haven't done anything about it. Absolutely. Let's go to number 2.
And we'll give this a couple more seconds, and then we'll be closing the polls. All right, 71% said false, 29 said true, and in investigating any complaint, it is more important to determine what happened than understand intent or impact of incident.
Right, this is another question where I expected a little bit more variability, but I would agree with the majority that the answer to this is false. Mostly because in doing an investigation, we have to look at both sides, and we have to look at the impact, and we have to determine how severe the situation was. So not only do we need to know what happened, but we need to know what the intent was and what the impact was. Okay, the last question.
Okay, we're going to get ready to close up polls. Give it a few more seconds. Okay, and 99% said all of the above. 1% said correcting the impact of misbehavior. So the question was responding to a complaint. It is most important to attend to, and like I said, 99% said all of the above.
Excellent. That I would concur. Excellent. Thank you, everybody, for responding and taking the time for the poll. It's always good for us to know whether the message is getting through. So terrific. In closing, let me share with you a takeoff on David Letterman, the top 10 actions to lessen supervisor liability, and see if you agree with these actions. They should spring from all the material we've talked about so far today. Number one is, do we clarify in writing with the supervisee not just the policy and procedures within the agency, but also some of these other issues here? Do we clarify in writing, in fact, engage in a consent, maybe even a written consent, signed by both the supervisor and supervisee that they intend to follow the rules, the policies and procedures not only of the agency, but ethical guidelines that are provided for the profession, and any other regulations that we're subject to. Is there a detailed supervision plan? Is there documentation of the frequency and the format for supervision? And is there a clear conflict resolution or corrective action guideline set in place so that if a supervisee has a complaint, they know how to go about voicing it, and they know who to report it to. Really important. We've talked about documentation just a bit. Creating a formal supervisory record looks like it's becoming increasingly important, especially, I would say for all supervisees. What I was about to say was especially for those supervisees who are just joining your agency or just joining the field and they're relatively new, but I would say for everyone. Because as we get older, there's pretty good indication in research that as we get older, our willingness to bend the rules increases. As our experience goes on, we begin to think that we can make decisions that are perhaps beyond our scope of decision making. So good to document supervisory sessions for all of our supervisees. In addition to those two, another guideline that we might want to think about at the agency management level is how do we assure that our supervisors are well prepared, are well trained, understand their roles and their responsibilities, making sure that we have good, competent supervision. Safeguard number 4, how do we make sure that we're practicing within the prevailing code of ethics? Do we review the code periodically? I know many certification boards and licensing boards require annual or every other year minimum amounts of exposure to training in ethics. I think I would encourage supervisors to bring that down to the agency level and review periodically, especially risky issues that are given some guidance within a code of ethics. Can we make sure, can we set a standard for ourselves? Can we raise the bar for ourselves so that we ensure that job performance on the part of every single staff member is above the minimum standard? That we let supervisees know that we're not expecting people just to meet the minimum, but we're expecting to go above and beyond the minimum standard. Less likely to have complaints and liability issues arise if everyone is doing a good job. Follow up complaints and concerns promptly and thoroughly, as we mentioned just a few minutes ago. If the supervisor encounters a situation where they're not sure what to do, management needs to encourage supervisors to go to a higher authority, to not make guesses, especially when it comes to having to act outside of traditional boundaries, reporting to a potential victim, for example, that someone has made a credible threat. Certainly needs the involvement of a higher authority than just the supervisor. So really letting our supervisors know that management expects to be told of situations that management might be called about from the local newspaper or the radio station. They need to be fully informed before they get that call. That clients in consent understand that their therapist is supervised, and that sometimes recordings are made for supervisory purposes. And they understand who that supervisor is, so that if the client ever had a complaint about the therapist, they know who to report that to. The courts are looking for those kinds of details in our policies and procedures. And do we do a good job of informing clients of their rights? Certainly reporting any potential threat to either the client, to the therapist, or to someone else's safety is critical. Needs to be reported to the supervisor, and the supervisor needs to take that to an authority higher to themselves to collaborate on what the appropriate response is. And then the last safeguard is maintaining ultimate respect and fairness for all of our supervisees. That supervisors aren't above and outside of normal, practical courtesies and ethical standards. We have our own ethical standards that we need to follow, and one of them has to do with treating people fairly and making sure that that is not only a written but a spoken value within the agency. So back to our original questions, and I'll close. I think I'm just about over time. Was Marcia at fault for literally neglecting her supervisory responsibilities? The answer to that would be yes. What's the legal standard for determining responsibility? Often comes down to negligence. Are we derelict in our duties in delivering good quality clinical supervision? Liability issues we've gone over, the absence of policies and procedures, the absence of monitoring performance, a failure to follow through with investigating complaints, not making appropriate corrections, all of those are liability issues. Are there some basic risk management principles? We reviewed those earlier. The answer is yes. How should we investigate? Thoroughly. And finally, what practical standards protect us? Following standards of practice, having clear agency guidelines in place, and implementing a clinical supervision program that's clearly articulated to our staff that takes into account the needs of our clients. That's it. Thank you so much. I think we might be a minute over time. We don't really have time for questions and answers at this point. I just wanted to remind you all that we're going to be doing a program on boundary issues. Some of the things we've talked about today kind of leak into that boundary area. We're going to talk more about boundary issues at our next program on June 8th. Tamara, I'll turn it back to you. Thank you very much.
Okay. Thank you, Steve. I just want to remind people that they'll get their CEUs immediately following this webinar. There is a short survey today. So if you could please take a few minutes and take that. Again, we will have the recorded webinars available for viewing, and you will receive information on how to access those. And that's it. Thank you very much for your time.